Today is January 31st, 2023. Welcome to The Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to find out how pharmacists and pharmacy students can improve population health, health equity, and patient care through advocacy and education. I'm Jeff Brappard. I'm a clinical professor of pharmacy practice at the University of Rhode Island and the academic collaborations officer at the Rhode Island Department of Health. Usually I'm joined by my P4 student, but she is interviewing for a job, so I get to ask the questions in a study that I was also part of. So it's a wonderful situation to be in. But let's get to our guests. We're joined by three guests to speak about their contributions to a recently published study that may be changing the landscape for opioid use disorder treatment. The MatPharm study, the first portion of it was published in the New England Journal of Medicine, which evaluated community pharmacy initiated, managed, and dispensed buprenorphine care. So thank you all for joining us today. We'll have you guys introduce yourselves. Let's start with Dr. Tracy Green.
Hi, I'm Tracy Green. I'm an epidemiologist, and I'm an adjunct associate professor at the Brown Schools of Medicine and Public Health, and also leading the COBRA on opioids and overdose, along with Dr. Rich at Rhode Island Hospital.
Wonderful. And then we'll go to Dr. Terranova.
Hello, my name is Andrew Terranova. I am one of the general pharmacists that was part of the study. I manage the pharmacy general pharmacy located in Providence, Rhode Island.
All right, thanks for being here, taking time out of your busy day. And last but not least, we have Rachel Serafinsky.
Hi, I'm Rachel Serafinsky. I work at Rhode Island Hospital as a project coordinator under the COBRA on opioids and overdose with Dr. Green.
All right. So I'll give a little bit of background here on why did we need to study expanding opioid use disorder treatment. So in the past year, over 100,000 people across the nation have died from an opioid-related overdose, which is the most ever recorded year over year here. Most of these deaths occurred in people who were not receiving highly effective treatment medications, one of them buprenorphine, which we focused on here. So what had happened is, or what previous to actually December, only certain clinicians who had applied for what's called an X-waiver for their controlled substance license from the DEA can prescribe buprenorphine. And even then they had patient limits who they were permitted to treat, and really depended on the training on how many patients. This is the only medication where we set these limits on in terms of number of patients, training required, and a registration process. So this results in less than 1 in 5 people who want treatment or who have an opioid use disorder actually get it. So it means 80% of people are not getting treatment. Some studies say 90%. So in response to this crisis and the clear need for increasing access to medications for addiction, the X-waiver program was eliminated as part of President Biden signing the Consolidated Appropriations Act of 2023. That had this piece of legislation called the Mainstreaming Addiction Treatment Act, or MAT Act, which now, in effect today, permits anyone with a current DEA registration to prescribe buprenorphine for opioid use disorder. But now, our study happened before all that, so we had to do lots of different things here. So let's just talk to our guests about how this study came about. So Dr. Green, or Tracy, we call each other first names here, I think. Congrats on the New England Journal of Medicine publication. Can you talk about your role in the study and why you wrote the grant, why Pharmacists for Addiction Care?
Yeah, I led the study and wrote the grant to initiate this really hypothesis, but it was well-founded because pretty much the rest of the world partners with pharmacies and pharmacists to provide addiction care. The United States is actually the anomaly in that regard. And with an opportunity, really thinking about those other spaces and places, we have an opportunity with buprenorphine in particular to extend care to more people. The data waiver you just talked about was an attempt, to try to make medication for addiction treatment easier for people by taking it out of the opioid treatment programs and putting it into the office-based care setting for physicians. Unfortunately, that only went so far. So it was an obvious place to extend access to treatment, and a safe one at that. Looking at the rest of the world, sort of seeing how well it had been done, and how normed it and standardized it could be, and really seeing so many wonderful pharmacy partners being able to do just that. So it felt like the right thing to test out at the right time, and in Rhode Island, the right place.
Thanks. I think I always want to, I like to quote from some of our partners that, buprenorphine makes sense in pharmacies because that's where the medication is, right? So if we're using medications for addiction treatment, pharmacies should be there. This paper reported early results from a segment of a larger funded study, a larger randomized control trial. How do these induction results compare to the results coming from the larger study?
Well, I kind of think of it as the dessert first model, where this is the most exciting part of the study, and the one that I think speaking for all of us, I think it's the thing that we kept knocking our heads against the wall, being, why can't we just start people on medication instead of having to receive patients who are already stabilized on medicine and caring for them in the pharmacy, which we were able to successfully do, but kind of heading to the point of the current New England Journal piece was, what if you could actually start them there and begin their recovery journey in the pharmacy environment and then continue their care there? So if you will, we'll get to the rest of the meal after having that dessert of being really excited about the opportunity that we saw in induction, which hadn't been done before, had not been done to the scale. I keep kind of pinching myself when I look at the past studies and realize, like, we have far exceeded any other pharmacy-based addiction care trial to date in this country, with this number of patients on buprenorphine in community pharmacies. And for this study, we'll continue to see how they carried on for 3 months in the pharmacy. But we're excited to sort of tell that part of the story too, but at least for getting us going and breaking the mold, the induction component was timely, and in my wildest dreams, I never thought the X-waiver would be X'd during the middle of the analysis and dissemination of this study. So I think it'll be it'll springboard into new opportunities for pharmacists and pharmacies. And
I'm crossing my fingers that I'll find out maybe in a month that we could expand within Genoa. So we're hopeful for those kinds of things, and with grateful assistance to Tracy for pushing me along, and our potential funders helping me out there. And so my role in the study was writing a CPA. I've worked with Tracy for many years on all kinds of pharmacy-based things. And then we said, I think Tracy wrote the grant like overnight one June. And then we said, hey, let's do induction, because the initiation of controlled substances, and especially buprenorphine, those rules were relaxed. And so we said, how about we do this? We got all the approvals through the medical board and the pharmacy board, and said, let's do this. So we wrote this collaborative practice agreement. I designed training. Andrew and his colleagues all got the same training that addiction physicians got, 8 hours of training plus motivational interviewing plus information on induction. And actually, we also in between had a withdrawal protocol where people could go to the pharmacy and get buprenorphine and to treat their withdrawal. All of those evaluations also part of it. We also did saliva testing, toxicology testing. Maybe Andrew can comment on that. But one of the things that we're getting with all the attention to the New England Journal of Medicine study is how could pharmacists do this? Because when the waiver existed, pharmacists were never part of that, despite my colleagues and I trying to get that to happen. The CPA in Rhode Island, and as all of us know, it's whatever happens in one state only happens in one state. So we're talking to other states about how to do this and replicate it. And so in Rhode Island, the pharmacist, Andrew and his colleagues, were lucky that it was passed 20 years ago to allow multiple physicians along with multiple pharmacists. We didn't have to have one-to-one as it exists. And the prescription is written in a DEA authorized way of one of the waiver providers who had patients within their patient limit. So all the patients who enrolled didn't put the prescriber, the prescribing clinician, the physician over their limit. And so the pharmacist did everything else in terms of testing and intake and all those other things. So we took highly trained pharmacists embedded in community mental health centers, so already sensitive to the needs of folks who have behavioral health issues, including opioid use disorder, gave them the additional medications for opioid use disorder training, how to communicate, how to do the testing, reviewed the CPA and all the things that are allowed in that. And so that's how that went. And so once we got that CPA approved, I think in the fall of 2020, we needed to start the study. So I want to switch to Rachel to tell us about what that first day was like. So I got to be there with her, but it was certainly an interesting day when I was quarantined at home just doing work and got the call. So Rachel, why don't you take it from here?
Yeah, I remember it was, the middle of the first COVID winter. So we were kind of all working from home, and we weren't doing a ton of outreach at that point. We weren't really sure how things were going to go with this new part of the study. And, everybody was kind of having trouble recruiting for research studies. And I remember we had posted an ad on Craigslist, and it was the morning after. I had posted it the evening before, and I was driving to the office, and I got a call from, our first patient, and they said, me and my partner would like to start buprenorphine today. We're not feeling very well. We'd like to go in as soon as possible. And I got off the phone with them, and kind of like this red alert went on in my head, and I was like, what am I gonna do? So I called Jeff and told him the situation, and he was on board to meet at the pharmacy at that moment. So we went to the pharmacy, we met the two patients, talked through the study, and Jeff and I were there to walk Andrew through everything, doing cows, taking their history, calling our study physician, Seth. And, Jeff and I didn't really have to be there. Andrew had everything down. It went really smoothly, and a lot better than I was expecting it in my head as I was driving frantically to go to the pharmacy, and it was great.
Yeah, it was interesting because of my role doing vaccination for COVID. This was January 2021, and so I had already gotten my vaccine in December. Rachel had not. I don't think anyone, Andrew, I don't think you had a vaccine. I don't think anybody was vaccinated. And so we're all wearing masks. The patients are wearing masks. But the other thing is that, remember this, as Tracy said, this is part of a larger study. So we had all these documents for doing patient intakes who were doing the maintenance part of the trial. The induction, I hadn't updated documents. So Rachel calls me, I'm like, I have to update documents and print all this stuff out and go down there. And we walk through all those steps. And, the memorable thing for me is the patient says, I think, and Rachel, maybe you want to talk about your role as recruiting them into the trial, right? You want to talk more about what those steps were?
Yeah, so as the project coordinator for the study, I, along with lots of help from my research assistant, Mercy, we do the recruitment, going out and doing street outreach and talking to people, at the bus station or at a community organization. People call us, they see our flyers. We're just kind of around everywhere, recruiting for the study, setting up rides for participants if they need it, helping them with phones or whatever they need, communicating between the study physician, Dr. Clark and Andrew and all of the other pharmacists.
Right. I think you mentioned some things I just want to go off on, is that and maybe Tracy, you want to talk about, or anybody, that this patient population was an extraordinarily marginalized, vulnerable population, and most of them had also been exposed to buprenorphine or have taken it in the past. Do you want to comment on that, Tracy?
Yeah, and I think just sort of placing it too in the time and space, which it's always helpful to turn back our clocks, really. At that time, in Rhode Island, as in a lot of states, we were seeing that care for people with opioid use disorder was extraordinarily strained. And Rhode Island, like those places, was trying to figure it out. And it motivated why we wanted to push forward to be able to provide induction care for the patients, not just because the study could do it, but because we felt that we as humans need to do this for our community. And so being able to, and reacting to the numbers and data that we had, which was the number of people, we kept hearing about people having a hard time in getting onto treatment, and induction was hard. People were not taking new patients. They were not going to their care providers. And at that time we had a nascent 24/7 buprenorphine hotline, which was great, but we didn't have the same sort of volume to meet the need. And this was another touch point. So if you didn't have a phone, or you didn't have a way to access that buprenorphine hotline or even know about it, you might cross paths with Rachel or Mercy in the field, or in a community program, or hear about or see a flyer and have access to buprenorphine care and start at the pharmacy with our study. So that that recognition that there were a lot of people who weren't otherwise touched by or reached by a traditional care provider, especially during the middle of a pandemic, but regularly are maybe having that moment during that day where, like, I'd like to start treatment, and not having a place to start to actually do so, and building new bridges and new partnerships, and in a place that in their community, a pharmacy that may be the right place to begin that journey. And but the fact remains that the folks that we were connecting with were many of those who were missed by those systems of care, the traditional systems of care, or maybe they landed in the emergency department as the place that they started, or the person where we have an extensive program. But those aren't really great beginning touch points that are, we could do more. And so to support that important time point, is also to be there for patients who may have access and need for transportation or communication, basic mechanisms that we know are important for successful supports. And so with the study and with the partnerships with the pharmacists and our capacity as a research program, we could at least offer some additional wayfinding and resources like a phone and transportation in particular. And then the resources that we knew of in our community to help support and access for folks during COVID, especially. There were more options for housing, for instance, in a temporary emergency setting, and food distribution points. So those are some things that we felt were additional supports for the success of the induction period supports, but obviously ongoing care, especially something like housing, is a key to success for maintenance as well.
Thank you for that. I think that's two important things that when we talk to other folks about replicating the study is that while buprenorphine could be stocked by some other pharmacy or some other Genoa pharmacy, they're not handing people phones and transportation vouchers, and they're not being reached by, most other pharmacies don't have their own outreach to recruit people. Pharmacies don't recruit patients to their to their pharmacies, because we're usually not starting meds. There's pharmacies that offer point of care testing and vaccination and COVID testing, but they don't have the outreach. And so I think that's the key. One of the key things is if you can do outreach, and like Rachel, that memorable call, like, I want to get treatment today, there's still no system in the country where you can say, I want to start buprenorphine treatment today. Only in very, very isolated ways do you have that sort of same day treatment. I want to switch to Andrew and say, how did the patients, going a little off script here, but how did the patients in the study, those induction patients, how did they compare to their life situation to the kinds of patients that you see at your pharmacy? Were they similar or different, or what would you say about that?
Yeah, I think being a Genoa pharmacist, we deal with a great variety of patients. We specialize in mental health disorders, substance abuse disorders as well. So some of these patients are very similar to the patients that we're used to providing care for. And, we're we pride ourselves in being a judgment-free environment for patients that do have some of these disorders. I think the thing that was different was doing the study and taking the time to sit down with each of these individuals was I realized how different each person was and the different challenges that they faced throughout their treatment journey that got them to coming into our pharmacy. Every person had a different barrier that they were facing, a different obstacle they were trying to overcome in order to get treatment with buprenorphine. And I think the individualized care that we were able to provide them once we took the time to sit down and get to know them was really the difference from some of the other patients that we see, because no two patients were the same, and they all really needed an individual treatment plan to meet their goals.
Wow, that's great. Do you have any particular patient story you want to tell or some anecdote?
Yeah, I think we've had a handful of successful, more than a handful of successful encounters with our patients. And, to this day, I have patients from the study that are no longer associated with our pharmacy that still call, and we'll chat with one of the pharmacists, myself included, to let us know how they're doing. We have many patients who started using our pharmacy because of their involvement in the study, and they continue to use Genoa Pharmacy as their preferred pharmacy. They still come in, they get their medications through us because they were so comfortable and satisfied with the kind of care and the quality of care they were able to get through our pharmacy, and that's all due to their engagement in the study. One particular patient had started taking opioids for pain. She was involved in an accident and was set up taking Suboxone through an outside recovery provider. Situations had changed. She was unable to continue seeing that provider and had been without her Suboxone for some time now. And her life had kind of started to deteriorate. She was having trouble maintaining a stable housing environment. She was having trouble with a custody battle over her son, which was due to some of these barriers she was facing to stay on her treatment. And and she had also was running into trouble at her job. Luckily, she happened to see the information about the study, contacted Rachel most likely, and was able to come in that day and meet with myself. And had it not been for that, pretty clear what kind of a path her life may have taken, if she was unable to come in and get started back on on buprenorphine treatment that day. So she was able to come in, start treatment, left the pharmacy that day with medication, and was a success straight through the study and made it to completion. And by the end of the study, she had custody again of her son. She was in great standing with her job, was working full time, and was able to provide a safe and a stable housing environment for her and her family. And that, who knows where her life could have taken her if she didn't have the access to buprenorphine that day, or wasn't able to come in and get seen when she needed it the most.
Yeah, that's a remarkable story. Really, thank you for sharing that. The thing that comes to mind is a person in recovery who's on one of the many committees that Tracy and I are on in the state, and that person was talking about buprenorphine as being the foundation for solutions for the rest of that person's life. And I just think about that, and that's why I think I and the rest of the team are so passionate to say, if you want treatment, as one of our other colleagues would say, the window of willingness, you got to be open to get that medicine to folks. And I think the other thing that's great about Genoa that we see in some other studies is that there's one study that shows 20% of pharmacies don't even stock buprenorphine. So even if you found a provider, used telemedicine and got it, imagine going to your pharmacy and they just didn't stock it, whether they were part of the study or not. So or had this sort of framework. So I think it's really important that we have this message of pharmacies need to be public health centers, but they can only provide public health if they have the medicines, on site for those types of things. And so I mentioned telehealth because that was what the state, which, may be going away, as we heard today. I guess the public health emergency is over in May. So that's a fun thing that we'll talk about some other podcasts. But the physicians on the CPA were able to initiate therapy after Andrew and his colleagues would evaluate the patient and get them in the systems. What was it like you call physicians all the time for questions, and you have physicians on site that you're very familiar with in the mental health community mental health center connected to you. What was it like talking to Doctors Rich and Clark about the patients?
It was a really it was a great experience from our end. The connection and the relationship that we were able to build with Dr. Rich and Dr. Clark as the pharmacists was great, and I think that was part of the success of the study too. Was we were able to call them whenever a patient came in and go over what we had gone discovered from our interaction with the patient about where they were at that point in time, and their medical history, and after our assessment give them basically, hey, this is what we came up with, this is what we think is going on with this patient, and have just an open conversation of, all right, thank you for the information, now how should we proceed for treatment. And they were wonderful to work with, and just learned a lot from my interactions with both Dr. Clark and Dr. Rich about substance use disorder treatment and buprenorphine prescribing. And I think that level of interaction that we were able to have was something that really kept the care for the patients consistent, and the relationship that we were able to develop really helped to make this study a success.
Yeah, I'm a big believer in collaborative care, and we hope that as we end the regimen here with the regimen for payment for services and things will be something that will come up. But one of the things I think that's interesting is now that we're in this post-waiver world where anyone, and we hope someday pharmacists will be able to get DEA licenses and be able to prescribe outside of a CPA or within it, what does that training look like? We did, you were part of the first cohort of pharmacists to get trained, and you had in-person training. Some of your colleagues had the online training from ASAM, the 8-hour training. And it's a one-time thing. We're talking about incorporating this into pharmacy programs. But what do you think about actually training alongside other physicians or NPs or PAs as they require this? Do you think that maybe those bonds form even before you have to work together? What would be your ideal type of training if you had to do that 8-hour training again for to prescribe buprenorphine?
Yeah, I think what you touched on there is exactly what I would say. I think the training was a great starting point, and it was great to get some of that information. And I know Dr. Rich came and talked to us, and we were able to talk to him during that training. But I think the more the study went on, the more I learned, and the better I became at assessing a patient's treatment needs, and realizing what we needed to do to treat them properly and keep them successful on the medication. And I think if we were able to have, pharmacists trained with some experts, whether it be providers, like you said, nurse practitioners, whoever who are experts in, substance use disorder treatment, maybe sit in and actually, learn hands-on, I think that would go a long way. The more, like I said, for me, the more I got to see kind of how Dr. Clark and Dr. Rich thought about patients and how they, their minds work to get to the treatment, I think I, excelled better at treatment myself. So that hands-on learning would be huge.
All right. Well, we'll see what we can do about that. So we have the regimen for pharmacist training, and now we need to where do we go from here? Since publishing the study, it's had exposure in the Boston Globe, and we were talking before on NPR. Andrew's voice is broadcast across the nation here, and in several other news outlets. It's become a key talking point in opioid education prevention programs. I just got another email today saying, tell us about the counseling that you gave patients. And so there's a supplement that I think people don't know about that has all the answers in the New England Journal of Medicine. But now I think we have evidence in favor of a pharmacy-based approach or a collaborative approach to addiction care initiation. So it's important we keep momentum and advocate for its implementation. So anyone can start. What do you think is the next best? What do you think are the next best steps? What do they look like in expanding this work or sustaining expansion of this work?
Well, I think a good bit of it is, as you've been alluding to, telling the story and, and actually telling the patient stories too, as Andrew shared today. And we've been trying to continue to hear from the perspective of the prescriber, Drs. Clark and Rich, from the pharmacists and from the patients. And that begins the, we are the stories we tell. And we're telling each other the story that it actually is working. It's working at multiple levels, and providing reinforcement that this is an exciting field to provide care. You actually get to see people's lives improve right before you by being part of this experience, and that systems can align to do that. The big alignment is payment, as it always has been, and then permission. So next steps for me, at least, and I think for many, are how do we help more states and jurisdictions adopt the capacity to legally do what we did, and then build the training to and the skill set and orientation to empower pharmacists to be able to provide this care in the environment, in the community that's quality, and then proper compensation for being able to do all those things, which take time and expertise. But we have a lot of the expertise already out there. We're just not using and optimizing it properly. So I think those payment mechanisms are really important to incentivize change, as they are for all systems of care, and professionals, to get to good quality outcomes.
So Rachel, what you were part of, you spent you and Mercy and the whole team spent lots of time recruiting these patients. Like, what would be, do we need to do a study? Maybe not, but like, what other than sort of longer term follow up with the patients, the patient stayed at, as Andrew said, at Genoa, what would you say, from your perspective, would streamline the system, since you were so active in that recruiting effort?
Yeah, I think one really important piece, and I know Jeff and Tracy, you both touched on this a little bit earlier, is connecting all of these pieces. So you have the pharmacy, which is very critical in low barrier access to care, but that doesn't work if there are other barriers in place with the patients. So I remember, if it's okay for me to share a story, I remember one instance that sticks out in particular among many, but we had a patient who, fell out of care for a couple of weeks and ended up calling us and letting us know that they had been incarcerated and they didn't get medication while they were inside, and they wanted to come back to the pharmacy, and they didn't have a phone. They actually just happened across one of the community organizations that we partnered with out in Providence, and didn't have a phone, didn't have transportation, and they were able to reach us. And I had called this person an Uber to get to the pharmacy, and I remember for whatever reason, the Uber driver had refused to take this person to the pharmacy, and this happened twice. So I ended up driving into downtown Providence and walking around and finding this person, and sat with them, made sure that they got inside the Uber, that they went to the pharmacy, and that wouldn't have happened without somebody to help coordinate that care. And I think that's critical for pharmacies and other places to have outreach workers or peer recovery specialists, or someone that can help coordinate and put together these other pieces. And then on the other side of that, if this person had an appointment at a doctor's office, they would have been late and maybe the doctor wouldn't have taken them, or maybe they needed the medication right now, but they couldn't get an appointment. So I think that, making sure that we can put all of these pieces together is really critical.
Yeah, I firmly believe that, if we're going to have a collaborative team of physicians and pharmacists, and, I know the technicians were great at Genoa helping out, everyone working a well-oiled machine there, but definitely incorporating peer specialists. And we realized very quickly that it's not the pharmacist's role to take in their social determinants of health and address them. And we had this research team, but having peer recovery specialists community health workers, social workers. We did interact with those folks. But as Tracy said, if you don't have a phone, you can't be in the study unless you have a phone, and you've got to have transportation. So the study provided that. That kind of outreach needs to be continuous, and I think that benefits not just people who need buprenorphine, but for all the things. We know 75% of people don't take their meds the right way. Pharmacists are a key part of that, but it really needs to be sort of a holistic community partnership. And so I think what the study has shown is that if you partner with those communities, they're not going to hear what I think a lot of us hear, which is those pharmacies don't stock those meds and they treat those patients badly. Maybe, as Andrew said about training, is we need a peer recovery specialist to talk to all the pharmacies and say, thank you, and we did this in a previous study, thank you for stocking naloxone, thank you for having buprenorphine. It's really important to me. I'm here because of you. And I think that that's what I've tried to encompass in training, is to say you've got to find the people with lived experience in recovery, and you've got to work with folks to make sure that buprenorphine is just another, or the medication for opioid use disorder is just another part of that foundation to rebuild their lives, as Andrew discussed. What's your biggest takeaway, Andrew? If you could make this study better, at the risk of publicly hearing this, what would you do? How would you make this better?
I think the kind of, just to reiterate some of the messages we've been going through, I think the overall coordination between the pharmacy, Rachel and the rest of the research team, and then the prescribers as well, was really what made this go. We can only do so much here in the pharmacy, but we needed the assistance from everybody else to really become successful. I think that the biggest piece that my takeaway would be just to see how appreciative they were when they would come to Genoa and be able to get seen immediately by a pharmacist. And we had a lot of patients. We talk about stigma and judgment, and that's something that they're going to encounter in any kind of health setting. I think to expand that, we need to obviously look past that as healthcare providers and as pharmacists, to make sure that we're providing that judgment-free care to people with substance abuse disorder and other diagnoses. I think that the study would be something that we could definitely try to expand as pharmacists, as our role continues to grow, and we look to continue to close some of these gaps in healthcare, and provide some of that middle ground between prescribers and patients, and kind of help to improve health outcomes for people in general.
Yes, we're hoping, one of the things that I can't not talk about funding as the regimen, but as Tracy and I and others have been part of discussions of, these billions of dollars in opioid settlement funds, and people are trying to say, what's the solution? And we start off by saying, 80 or 90% of people don't have access to therapy. And we did the study in a state that has lots of pharmacies, lots of healthcare, fewer limits, no prior auths on buprenorphine. We offer, Tracy was part of a team to start treatment start the nationwide push, not quite there yet, for prison-based treatment initiation and continuation. And so despite all that, we still see, 2021 was still a year that had the highest number of opioid-related overdoses ever in Rhode Island. So we know that treatment saves lives, and we know that not only do people need to be able to get access to that treatment without barriers, we need the people providing that treatment to have fewer barriers. The X-waiver is gone. So Tracy, why don't you close us out for what your vision is of where this research goes?
Yeah, I think, some is immediate and exciting and kind of novel, cutting edge thinking. And then the other, I think, just to reiterate some of the things that Andrew pointed to, when we asked some of our international colleagues about how it was going in Australia and Canada and Scotland in the pharmacies, and one of the things that was consistent was ongoing continuing education on stigma and harm reduction in particular, but especially on stigma and addressing stigma in the pharmacy. And I think that was a real reflection, even though they had been doing this for quite some time, that it is it's caretaking. You don't take your foot off that gas. And it's a much bigger than a course or a training or a certificate or any one thing. And it is a lifetime and a professional commitment to continue to work on improving and reducing the chances that a patient's going to have a poor experience just by the basis of their disease or their skin color or their other constraints in their lives. So I think you have a chance to continue to work on that. And there are new ways of doing so. But I think also the opportunity of new medications, injectables, for instance, long-acting injectable medications are just around the corner. We have some already for buprenorphine delivery, and that'll be an exciting next frontier. And then, we're starting to understand a lot more about fentanyl and illicitly manufactured fentanyl's effects potentially on the human body, and thinking about different kinds of dosing regimens for patients that might be better treated with a higher dose start or a smaller doses start, macro dosing and micro dosing. These are things that I expect pharmacists to be expert at and be very comfortable talking with patients about. So I think that's a really exciting place for what the future may hold in terms of collaborations that advance options for patients in the many different places that a community pharmacy can take this care model. So.
All right, thank you very much. Yeah, I'm very excited about injectables. Rhode Island now allows long-acting injectables to be given by pharmacists, thanks to a law passed in 2021 and some regulations my students and I helped write. Yeah. So Andrew, get your hands ready for those long-acting medications. I know Jenna is a big supporter of those kinds of things. Any other last thoughts? Otherwise, I'll take us out. Okay, so I'd like to thank our guests for the generous donation of their time here and providing amazing insight on this critical aspect of judgment-free patient care and expanding pharmacy practice. Everyone be sure to follow at PharmDPubHealth on Twitter and Instagram, and subscribe to at PharmDPubHealth on YouTube, where you're watching this right now, and stay tuned for next week's episode on the recently expanded access to mifepristone for reproductive health through pharmacies across the nation. Thank you very much.